Osteoarthritis clinical case. A 68-year-old female with knee osteoarthritis and hypertension. She's taking enalapril and hydrochlorothiazide. Enalapril is a derivative from the angiotensin converting enzyme inhibitor, and hydrochlorothiazide is a diuretic. Both are used in the management of the hypertension. She frequently takes diclofenac for pain, non-steroidal anti-inflammatory drug, and she presents with reduced urine output and elevated serum creatinine. Urine output is reduced and elevated serum creatinine. So this is the case of the drug-drug interaction. Age is 68 year and the female, because the gender here is important, because females are more prone for the osteoarthritis as compared to male. The question is, what is the likely cause for her renal impairment? Why urine output is decreased? And this effect is called triple whammy interaction. Triple whammy interaction. What is triple whammy interaction? Or we can say non-steroidal anti-inflammatory drugs induced acute kidney injury. What is triple whammy? When the patient takes these three drugs, and due to interaction of these three drugs, there is the acute renal or acute kidney impairment or acute kidney injury is called as triple whammy. Which are these three drugs? The first one is non-steroidal anti-inflammatory drug. In this case, patient takes the diclofenac. Non-steroidal anti-inflammatory drugs, that is diclofenac, angiotensin converting enzyme inhibitor, enalapril, and diuretic hydrochlorothiazide. If the patient takes these three drugs at one time, this interaction leads to decrease in the renal perfusion, and that leads to the acute kidney injury. And this effect is called as triple whammy. How it caused the triple whammy or acute kidney injury? The first drug, non-steroidal anti-inflammatory drug, it constricts the afferent arteriole. So what will be the effect? It decreases the blood entering the kidney. Decrease the blood entering the kidney, decrease the urine output, because filtration will affect. Second drug, angiotensin converting enzyme inhibitor or angiotensin receptor blocker. This drug dilates the efferent arteriole. What will be the effect of dilation of efferent arteriole? It will decrease the pressure inside glomerulus, and that also decrease the urine output. Third drug, diuretics. In this case, patient takes the hydrochlorothiazide that decrease the blood volume, dehydration, decrease the urine output. These all three drugs decrease the urine output, combine effect, marked decrease in the GFR, and decrease the and it leads to the acute kidney injury. So triple whammy effect. Triple means three drugs. Which are these three drugs? NSAIDs, ACI inhibitor, and diuretic. What is the effect of whammy? It causes the acute kidney injury. How? It decreases the urine output. So this is the case of drug-drug interaction. The patient of osteoarthritis on hypertension management drug like AC inhibitors and diuretics. Now, if these three drugs, which are most commonly used drug, if they cause the triple whammy, what is the safer analgesic option? So paracetamol, because as we discussed in the before case, the age is more than 65. It when we take the non-steroidal anti-inflammatory drugs that reduce affects the kidney function. So paracetamol is the first and preferred drug in the management of osteoarthritis, and first line and safer in the elderly with the comorbidities like the uh, hypertension or diabetes mellitus. What is the recommended management? Here, we need to stop the non-steroidal anti-inflammatory drug and replace with the paracetamol, monitor renal function, and switch to the topical NSAIDs like the diclofenac gel, diclofenac ointment, creams are available, or paracetamol replacement with the uh, diclofenac. So, what will be the updated plan here in the focus of the drug-drug interaction? Avoid chronic NSAIDs in the elderly with the comorbidities like the diclofenac, ibuprofen. Prefer paracetamol, and if the paracetamol is not getting benefit, then use the diclofenac topical ointments. Monitor renal function when combining antihypertensive. So this is the best example for the drug-drug interactions, triple whammy effect. Now, let us see the Gouty arthritis. Before we seen rheumatoid arthritis, osteoarthritis, and now Gouty arthritis. Clinical case. A 50-year-old male present with sudden severe pain in the first metatarsophalangeal joint, that is a big toe, at night. The joint is red, swollen, and extremely tender, and serum uric acid is elevated. Age is 50-year-old, sudden severe pain, and metatarsophalangeal joint is affected. What is the diagnosis? Acute Gouty arthritis. Why acute? Sudden severe. Sudden severe, acute. So this is the classic podagra. What is podagra? When there is a severe pain, sudden severe pain in the big toe, this is in the podagra. With the red, swollen, and extremely tender, and hyperuricemia. So the case is obviously Gouty arthritis. What is the drug of choice in the acute attack? Now, if there is an acute attack and the first time, we need to manage by the pain relievers. And amongst the pain relievers, we need to give indomethacin is the first line therapy for the acute inflammation. Indomethacin is an non-steroidal anti-inflammatory drugs. Once the pain is subsided, then we will start the therapy for the Gouty arthritis. What is the role of colchicine here? The colchicine is a primary drug and used in the Gouty arthritis, and it should be used as alternative if the patient is not getting benefit from the non-steroidal anti-inflammatory drugs or non-steroidal anti-inflammatory drugs are contraindicated. How it acts? The colchicine, it inhibits the microtubules and reduce neutrophil migration. This reduction in the neutrophil migration will reduce the inflammation, pain and inflammation. So colchicine will reduce the pain and inflammation, but remember it will not reduce the serum uric acid. Why should allopurinol not be started during an acute attack? As we know that allopurinol is the preferred drug in the management of Gouty arthritis. Why should not be started during the acute attack? Because the allopurinol may worsen the attack. How? Because the changing uric acid level, especially rapidly, irritates the joint, which triggers the inflammation. And in the acute attack, there is already inflammation. So that's why it worsens the inflammation. Once the pain and inflammation is subsided, then we need to add allopurinol. So we need to start only after the acute phase subsides. Pain, inflammation subsides. What is the mechanism of allopurinol? We already discussed in the previous block. Xanthine oxidase inhibitor. And this xanthine oxidase enzyme inhibition leads to decreased uric acid production. So what is the treatment plan here? For acute attack, we need to give first, if acute severe sudden attack, we need to give non-steroidal anti-inflammatory drugs like indomethacin, naproxen, or if the patient get the benefit from the diclofenac, it's okay. Then colchicine. When we need to give colchicine, if the indomethacin or naproxen not getting benefit or contraindicated. And remember, colchicine does not reduce the serum uric acid. It will only help for the pain and inflammation. And if the both drug, NSAIDs, colchicine, not getting benefit, maybe the corticosteroids is used for the severe cases. Chronic management. Once the pain subsided or the patient has a chronic stage, then go for the allopurinol or febuxostat, one of the drug. The most commonly used drug is allopurinol. It will decrease the uric acid synthesis and thereby reduce the gout. Now, probenecid. Probenecid is uricosuric agent. It will increase the uric acid excretion. Increase the uric acid excretion in the urine. So it is called uricosuric agent, probenecid. And the drugs that decrease the synthesis of uric acid is allopurinol. And obviously, the lifestyle modification, reduce alcohol intake, avoid purine rich food because purine and protein rich food, the byproduct is uric acid, and increase the hydration. Uh, Sufficient amount of water will take out the uric acid crystal into the urine. And this is the last case of the Gouty arthritis. A 55-year-old male with gout and IHD is on aspirin. Aspirin, low dose aspirin. Low dose aspirin is recommended in the patient of cardiovascular disorder. Aspirin low dose because it will act as antiplatelet. Aspirin. Atorvastatin, statin, atorvastatin, and warfarin. Atorvastatin generally used for the patient. These all derivatives of the statin, atorvastatin, rosuvastatin, these are used in the management of the lipid profile. And warfarin, the warfarin is the blood thinner to avoid the clotting. So aspirin, atorvastatin, and warfarin, these are the main target or preventive medications in the management of the IHD. So if the patient has the high cholesterol and triglyceride, and to avoid the heart attack and stroke, we need to give atorvastatin. So case is 55-year-old male with gout and he has IHD. He is taking aspirin, low dose, atorvastatin, and the warfarin. He present with recurrent gout attack and he started on allopurinol. So this is the case of drug-drug interaction. What is the interaction between allopurinol and warfarin? Allopurinol is important for the chronic gout and warfarin is the blood thinner we need to give to avoid the heart attacks and the stroke in the patient of IHD. The drug-drug interaction is allopurinol inhibits the metabolism of warfarin. And if the metabolism of warfarin is decreased, it will build the drug in the body that leads to toxicity, and toxicity of warfarin is increase in the bleeding risk, internal bleeding or hemorrhage. Second question, what is the effect of low dose of aspirin on the gut? Okay, low dose of aspirin generally used as an antiplatelet agent to avoid the heart attack and the stroke and preventive medication in the ISD patient. But with the allopurinol or with the patient with the increase in the serum uric acid, the aspirin, the low dose aspirin will worsens the hyperuricemia because the aspirin will decrease the uric acid excretion. So that's why the patient experience recurrent gout attack with the medications of aspirin, low dose aspirin. Question number 3. Which drug interaction increases the risk of myopathy? Yes. Now, atorvastatin. The statins derivatives are used to lower high cholesterol and triglycerides, and it will reduce the risk of heart attack and stroke in the ISD patient. And colchicine will reduce the inflammation, and most recommended drug in the management of gout. If these two drugs are combined, it will increase the risk of muscle toxicity, myopathy, or rhabdomyolysis. And remember, the colchicine act by inhibiting microtubule formations in the inflammatory cells and reduce the inflammation in the gout. So if the patient on colchicine therapy and taking the atorvastatin, the adverse effect is myopathy, the pains in the muscle. What precautions should be taken when starting allopurinol? Start at the low dose and give preventive or colchicine or NSAIDs to prevent the acute attacks. As we discussed before, the allopurinol should not be taken during the acute attack because it will worsen the attack. So that's why once the attack or pain or inflammation is subsided, then we need to give the allopurinol. What is the best management strategy in this patient? The best management strategy is continue allopurinol because the chronic case, check the dose, monitor for the INR. This INR means international normalized ratio for warfarin interaction, or to check the clotting factor of the drug to avoid the hemorrhage or bleeding, and avoid unnecessary aspirin dose escalation and use colchicine cautiously. So updated treatment plan for the drug-drug interaction focus. We need to monitor for the interactions. As we know that allopurinol with the warfarin, the bleeding risk, colchicine, statin, myopathy, modify therapy carefully in comorbid patients, and plus lifestyle modification is very important. The diet, the rich in the protein, purines should be avoided. Urate lowering therapy is essential. So these are the management plan for the osteoarthritis.